I think now you're all set. Can you see it properly, Antonia?
I see it, but it's not in total presentation mode. I see your other tabs if you wanted to change it.
I think that's you because it's a Mentimeter. I'm not sure.
Oh, right. Okay.
I think that's how it is. Yeah.
It's a pretty good look. So yeah, go ahead.
Yeah, fair enough. Okay, cool. So welcome everybody. Thank you for joining and for being interested in a topic that I'm pretty passionate about, which is pediatric migrant health. So let me see if I can move this forward. Yeah, so my objectives for this presentation are split up in between like the global level, the macro level, the meso level, that's the institutional level, and the micro level, which is the level of the families. And on the macro level, I would love to give you a quick overview about key frameworks and evidence in the field of pediatric migrant health, as it's a pretty young field and not many people are familiar with it. Then on the meso level, so the institutional level, I would love to introduce you to important inequities and challenges when providing care to pediatric migrants. And also I would love to offer some strategies how we can solve those challenges. And on the micro level, I would love to introduce you to approaches how you can support the delivery of diversity-sensitive care to migrant families. To make this a little bit more fun, I use this program called Mentimeter. First of all, it's just fun for you to interact, and second, it also helps me to see a little bit what people know and what they don't know, so I can adapt this as good as much as possible to the audience, so that you have hopefully a good takeaway from it. So to participate, you can just take your smartphone and either scan the QR code or go to menti.com and put the code in, and then you're all set, and then you can participate in some of the questions. They're all, we'll all not see your name, so it will be easy to participate. You won't put yourself on the spot. I also put the code in the chat, just in case people drop in a little bit later, then you can still participate. All right, I can see 16 people already signed up. Perfect. So let's get started. As Antonia said, I'm an emerged pediatrician, and as such, I sometimes like very concrete examples to know why I should worry about something and not worry about 5 million other things that I should be worried about. So I luckily had the pleasure to treat one kid and one family at home in Switzerland who were willing to share their story. So this is a real case. It was a summer day in the capital of Switzerland, and Johnson presented. He was a 4-year-old boy at that time, Eritrean. His mom spoke very little German, and we spoke very little Tigrinya, so it was hard to communicate. He was seen, that's what the triage nurse figured out, 3 times before by his general practitioner for a complaint that mom described as a sore throat. At the same time, you know, emerged came a kid with a huge dog bite. The triage nurse needed to rush. She did the pediatric triangle, saw he's breathing fine, he looks fine, his skin looks fine, so great. He got the lowest acuity score, the gray one, and was waiting in our department to be seen. I was the staff that day, and a doctor in residency who was new to pediatrics, excellent doctor, went in, and I felt like perfect match, so she can take all the time that she needs to do history and exam. So we had issues to get the interpreter in the right language, and when she came out of the room, she was like, somehow it's hard to look in the mouth of that kid. And so we went together, and the mom told me, yeah, sore throat, but pointed on the outside of the throat. And when I looked in the mouth, it looked all completely fine. And when I set the kid up, suddenly he looked like this. So he turned his head, and I was like, okay, that's weird. Maybe she means something else with this sore throat. And when we examined him further, we realized he had an abducens paresis. That's a paresis of one of the eye muscles. That is a real danger sign for increased pressure in the brain. In addition, the mom, because we still had no interpreter, showed me that picture on the right side there, which is showing a kid in an opposite tone position. That's also a red flag for increased intracranial pressure. So the whole neurologic exam was incredibly pathologic, and we were increasingly worried about him. Got an emergency MRI, which showed that he had an ependymoma grade 2. And those two, I don't know how many clinicians are here, probably many. So forgive me if I explain it a bit easier so everybody can participate. The two big round circles that look a little bit like tunis, they are the ventricles where the brain water is collected. And they usually are tiny. And in this case, they are really, really big. So that means that the brain water has a hard time to get out. And it's really quite a late sign of a brain tumor that is kind of blocking the brain water from getting out. So we quickly called the neurosurgeons, and he received emergency neurosurgery that day. So now let's zoom out. Let's keep that case in mind and zoom out on the global level. What is out there for children like Jonathan? What is described in healthcare? Or no, first I want to ask you something about epidemiology. Like, how many children do you think are out there, like Jonathan, that have migration background and crossed an international border and are therefore considered international migrants? And how many of these are here in Canada? I will hide the results so that you get not influenced by the others who vote. I already got 6. Well, you're fast. Amazing. Thank you. All right, let's have a look. Okay, the majority says 7.2 million. Excellent. So Canada is one of those diversity-rich countries. In total, we have 281 million international migrants in 2020, which is 3.6% of the world's population. In this beautiful country here, in 2022, we had 8.3 million international migrants. That's 23% of the population, and that is the highest since Confederation. The highest proportion of immigrants was in 1921 with 22.3% so far. So Canada is as diverse as never before since Confederation, and therefore this is quite an important, like the international migrants form quite an important part of the population. And to give you a longitudinal perspective, there was a steady increase in international migrants since the 1990s, but as the global population grows as well, it was pretty stable. So it's about like always 3.5% of the global population. So quite a good amount of people. On the WHO level, already 1946, after the devastating experiences of the Second World War, many countries came together and wrote the Right to Health framework. And this means that everybody has the right to the enjoyment of the highest attainable standard of physical and mental health. And I was very pleased when I prepared for this talk that there was a Canadian right at the core of the team who produced this amazing framework. And what I found pretty interesting is that already at that time, those people acknowledged that pediatric migrants are put in a vulnerable position twice. First, by being children, so they face particular health challenges related to the stage of their development. And second, by being migrants, because as migrant, you are at risk to be discriminated by national law. For example, if you don't have full health service access, but only access to essential care. And so those children are 2 times put in a vulnerable position. Another important milestone on the macro level was the Global Compact for Safe, Orderly and Regular Migration, developed by many UN member states, and it is also part of the Sustainable Development Goals. And this is really a beautiful theoretical compact that embraces a lot of important aspects to ensure safe migration, including healthcare. In Objective 15, they in detail really specify that there should be in every country trained and culturally sensitive health workers, that they should strengthen the capacities for service provision, that the country should produce affordable and non-discriminatory access and reduce communication barriers. So very detailed. The problem of this global compact is that it's kind of teethless because it's non-binding. So as many of you are researchers, I would like to introduce you as well to a pretty beautiful piece of evidence that is summarizing research frameworks for pediatric migrant health. And to warm you up for this paper, I would love to ask you, do you think migration is a consequence of social determinants of health? Or do you think it changes an individual's social determinants of health? Do you think it is a social determinant of health itself, or do you think it's all the three? Just to give the others a little heads up, so we are using to make it more fun Mentimeter, and I put in the chat the link to the website and the code if you want to log in as well with your smartphone. If not, no worries. All right, we already get 16 answers. Let's have a look. Hey, you made my day. Thank you. Exactly. And this is what these authors introduced already in 2015. So they said that the effect of migration on health is so complex and so important that it's not only influencing the social determinants of health of a person, but that it is a social determinant itself. And as such, it needs to be assessed also in different studies, particularly in populations that are very diversity rich. The authors further distinguished 3 different research frameworks. The first one is the most commonly used. It's called behavioral framework, where the individual is the unit of analysis. So you, for example, take migrant children and you look, how many of them are vaccinated. The second framework that's already a little bit less commonly used is the cultural framework. So there the unit of analysis is a cultural group, for example, Hispanics living in the US. And then your outcome would be things like gender equity. So the advantage of that model is it looks already a little bit from a broader perspective and takes culture really serious and into account. The danger is exactly that culture is kind of over appreciated, and it may have the tendency to include stereotypes like machismo, although the group of people that is in this cultural pot of, for example, Hispanic origin US citizens is very heterogeneous. So that's a little bit the tricky side of that framework. The third framework is the least commonly used, and the authors of that paper strongly advocate for this framework, and that's the structural framework. A structural framework really uses the large-scale structure as unit of analysis. So, for example, immigration category or immigration status. And then it looks how does this structural component influence, for example, employment or mental health. And the beauty of this approach and why they argue so much to use it is that you're already one step closer to the solutions. In the other frameworks, you always have then in your discussion to think, which structural elements are influencing my findings. And on that level, you just examine the very same structural elements, and then it's easier to create a meaningful intervention that improves public health for migrants. A second important theory mentioned on a global level is the theory of migration channels. So Leong Centre introduced or defined migration channels as mobility pathways structured by different actors. So these can be states or profit-oriented actors or individuals. And by having one channel through which a person comes, this person experiences specific opportunities and constraints. The channels that were defined in that study was first a family-oriented channel. So that's for people who come to another country for family reunification, for example. They have a big advantage that they can directly access a social network, which is great. But many times the person coming is very dependent on the person inviting. So if there are issues, that person might have limited access to care. The probably globally most frequently used channel is the company-oriented channel. So that's people who have a work contract and already come to that country for work. Basically, all your clinical fellows. So the beauty of that is that they have financial security because their work permit is already there, like really on the go. That's why they came. But there might be an issue with the social network. So if there's not a good community, those people might have a little bit more a hard time to access the community, not like the family-oriented who already have their family right there. Then there's the study-oriented channel, that's students. And then one channel I would love to focus also in the next couple of minutes on is the protection-oriented channel. That's the refugees. They come through different resettlement programs or through in-country asylum programs, where if successful, they are granted permanent residency. And the reason why I would like to focus on this small but very important group is that there is a huge risk of trauma and health problems that have been related and neglected in the past. So how does it look in Canada? Well, these numbers are a little bit special, I have to warn you. I just wanted to use the most recent ones I could get, but they are, of course, from the pandemic. So they're even a little bit less pronounced than in normal years. What you can definitely see is that economic immigrants are the vast majority. And then you have the smaller but important subgroup being refugees and protected persons. And protected persons in Canada is a group of people who are asylum seekers who came into the country, claimed for asylum, and were successful. And yeah, the numbers are pretty clear that the economic immigrants are the vast majority. So let's now move to the institutional level. So, for example, to an institution like CHES. This is the migration cycle. This is used since years by many migrant health researchers and also migrant health care providers. And why I'm showing you this is basically to illustrate that migration is not like a journey in one direction. It's very, very diverse as the migrants themselves. It involves particularly in the group of people forced to migrate. Many travel and transit countries. So for a person forced to migrate, the escape or the migration usually takes 7 to 8 years. And it might go back and forth and back and forth. And eventually they may return to the country they came from. So it's more, it's better understood like a cycle rather than like a line from one place to the other place. And of course, we'll focus on the country of destination. But just to put ourselves a little bit better in the shoes of our patients, I'd like to give you just short screenshots of potential countries of origin. So if you're a migrant forced to flee from, for example, Niger, this was the kind of moment when you presented to a healthcare facility. So many pediatricians probably are now, oh, give him fluids. So this kid is a child that is severely dehydrated, luckily not malnourished. And this was kind of a very typical presentation in the hospital, in a hospital in south of Niger. So nobody would like run a huge resuscitation immediately and everybody would run. It's kind of the way the patients unfortunately many times present. And if now such a family fled because like the global warming just made it impossible to do agriculture there, which is like the backbone of the south of Niger, and they had to migrate and like spend many years in a transit country and then came to Canada. And then the nice Canadian doctor explains them, well, your next visit, you come just with your healthy kid. It might not come natural to them. They might be, why should I go to a doctor if my kid is healthy? I go to a doctor when my kid is sick, you know? And then the doctor might get grumpy because he scheduled a beautiful preventive care appointment and the family is not showing up. So it might be because their background of experiences is I go to the doctor when my kid is really sick. And it can help us understand decisions better and be less grumpy, more understanding if we know what the previous experiences of the family were and how their rationale to seek care was before they came. This is a typical country of a transition country or a transit country. This is just a picture from Nduta refugee camp. It's a camp on the border to Burundi and Tanzania. So many Burundian refugees. And as you can see, kids get born there, people have their life there. So it might be that the migrant sitting in front of you has never been in the country of his nationality. So this little one on the right is Butoy. He was our youngest and lightest patient. He had 900 grams. And usually those kids don't survive in that context, given our limitations in terms of healthcare that we can provide. And he made it through and is now a happy 5-year-old. So that's pretty spectacular. And it just is to illustrate that people may not even have lived in the country where which is written on their passport. So now let's go to the destination country that may look a little bit more like this. So what do you think? What particular challenges do you experience when providing care to international migrants opposed to non-migrants? This is just, you can just throw whichever word comes first to your mind. And I have my secret guess what comes first. Language, I knew it. Exactly. Yeah, poverty, trauma, yes. Exactly. Anything else that comes up in your mind? Language barriers, yeah. Culture, miscommunication, culture damage, exactly. Mistrust, oh, fantastic, thanks for that. Yeah, absolutely, thank you for that. Okay. When I started doing pediatric migrant health, we started first with a literature review to see what's out there and what challenges are described. And our goal was really to not do a super complicated graph, which is maybe very comprehensive but hard to use in busy daily life. So we try to condense all the challenges described into an easy model, usable for healthcare providers on the institutional level. And what all the studies, or most of the studies really mentioned, were the following 3 challenges. So the first one is communication, mentioned by nearly all the healthcare workers immediately, because that's really the obvious one we see every day. Then also confidence, and that includes 2 things. And one, a trustful patient healthcare provider relationship, and second, that the family feels they have a say in what's going on. And that was the second major challenge. And the third one was continuity of care. What's important in this pretty pragmatic model is that it's embedded in the cultural context that you actually work in, and that influences, of course, the way those 3 challenges play out. So me coming from Switzerland, we have really an issue with discrimination, or we don't have good anti-discriminatory legal frameworks. And we kind of score 50 all the time in the Migrant Integration Policy Index that compares different countries. So there's much to do about that. But we don't have so many geographical challenges because we are very tiny. So that's not the problem we are facing. Whereas Canada, I felt, is a little bit the opposite. I find there's a great awareness of discrimination and also an effort to produce anti-discriminatory laws. But the geographical challenge is definitely there. So maybe it's not a good place to put a recently arrived refugee family with a child with complex health needs in the Northern Territories, but they would have long journeys to access tertiary care, for example. So it really depends on the context, how these challenges then play out. Let's first focus on continuity of care. And to make it a little bit more interesting for you, I also included a case from Ontario. So one winter day at the Sick Emergency Department, another 5-year-old with shortness of breath came. So what we usually think there is, yeah, probably a virus. Let's get the ventilator ready. He probably has asthma. We needed an interpreter that was a little bit tricky to get. I'll keep it a little bit vague in terms of his country of origin for confidentiality reasons. But we went in, we thought, okay, let's do an exam. His vital signs were pretty decent. But when we listened to his chest, nearly without a stethoscope, you could hear a heart murmur. So we did a focus of the heart, and the left the image on the left side is his heart, and that on the right is a normal one. So basically, it completely exceeded our emerged cardiology knowledge. But what we saw was, whoa, there's something really wrong going on. So if you look, for example, in the middle, you usually have that line separating the left and the right heart, and there's just no line between the two ventricles of the heart. And what then cardiology relatively quickly figured out was that this child had a complex cardiac heart disease. So these children in Canada ideally would have been identified antenatally in one of the ultrasounds. So that's one of the major reasons why we do these ultrasounds. And since that moment, even before the child would have been born, a child would have been treated differently with great care. And so this boy was just 5 years running around with this complex cardiac heart disease. And those presentations can sometimes be really challenging, that you're there and you're like, oh my God, where should I start? And in our European guidelines for the care of migrant children in Europe, we took the evidence that was out there and developed an acronym, which is called HEALTH. It stands for Home, Escape, Arrival, Language, Transition Countries, and Host Country. And as you can maybe already see, it's oriented on the migration cycle. And it's usually easy to use because the people who migrate, it comes natural to them to report that way. And if you apply this to this case, we quickly figured out that, okay, he comes from a sub-Saharan African country, had already one admission to a hospital when he was 2 years. They detected a heart murmur. Mom was told he had only one ventricle, but that the gold standard treatment was not available in the country. So since he was 2, Mom carefully planned her migration with her son and saved money to do so. She luckily was a highly skilled person in the country of origin, a vice president of a real estate company. She was a single mom, so that made it more complicated for her to organize everything. But she finally got her plane ticket and moved to Toronto in December 2022. Even if her own reason was to get healthcare to her child, she got then stuck in a lot of administrative issues and competing interests, like very concrete questions like, where can I sleep? How can I pay this rent? How do I get my residency status? How do I get access to healthcare? So all these very important, essential competing interests, which delayed the presentation of her child to care, and unfortunately ended up in her son being acutely sick and then ending up in an emergency department. This case is also just to illustrate you how the migration channel plays out in the specific case. So ironically, she didn't come from a country that would have been eligible for a resettlement program. But if she was, she would have been absolutely prioritized as a mom of a child with a complex disease and a single mom. And then through that channel, they usually get excellent care. Like they get OHIP at arrival. Sometimes they come directly from the airport to the hospital or the day later. So as she was an in-country applicant, her administrative process was much more complicated and not organized. She didn't get that support that she would have received if she was a government-assisted resettled refugee, and therefore things got delayed. So let's focus now on the next challenge, confidence. And one of you mentioned mistrust, and I love that. Thank you for that, because when we did a qualitative study and asked our asylum-seeking caregivers what's actually important to them, they, surprisingly enough, also reported those 3 challenges, but they kind of flipped the triangle. Whereas the healthcare workers were like, communication, that's my number 1. They said, well, confidence is my number 1. And even if I can't talk to the medical team, as long as I trust them, it's okay. It's better than communicating with them but not trusting them. And having done all those interviews, I was really wondering, how can I become such a diversity sensitive health worker if that's like so important to my patients? And an anthropologist I had the pleasure to work with, who also did the qualitative work with me, shared this Kleinman cycle with me. And she said, this is the most pragmatic you can get in anthropology. And it's pretty pragmatic. So I was very thankful for that. So it's easy to apply even for us emerge docs. And it's based on a very easy to remember sentence that another anthropologist at Doctors Without Borders once told me. She told me all the time, don't assume, because if you assume, you make an ass out of you and me. Just ask. And then you are wondering, what should I ask? And what this model shows is that 2 questions are extremely important. One is, what is at stake? For example, in Jonathan's case, the boy I introduced you to with the brain tumor, the first thing the dad said was not, oh no, what kind of surgery will we do for my kid? The first thing was like, oh no, I will lose my job. Because he felt like, oh my God, now I need to be in the hospital the whole time. And the whole existence of the family was built on his job, because if he lost the job, he would lose his permission to stay in Switzerland, and they would have had to go back. So it was extremely helpful for them that we called his employer and told, hey, we have an emergency here, he needs to stay with us. And then the employer was immediately very collaborative. So that it might be different what's at stake for the migrant family than what you first think. The second super important question, where I learned so much in my clinical practice, is to ask about the illness narrative. So what do you think? Where does this come from? Usually all the parents have some why, because it's hard to tolerate that your kid is sick and not a little bit wonder why. No, that's kind of part of our nature as parents. And when we founded a sickle cell clinic in Niger, I learned so much from the parents, because they told me it's a bones disease. The disease comes from the bone. And when you know what their explication is, you can take it up from there and then say, yes, exactly. But in the bone, there are vessels, and those and there are little things in there that usually look like full moons, but in your case, like half moons, and get blocked. And that's what causes the pain. And by choosing an approach that is based on the parents' way to explain the disease, they sometimes are just so happy. Like many of those mothers of the sickle cell clinic were super, super happy. And then the adherence was also very, very good. So, and you learn a lot about diseases and how you can explain them. So these 2 questions, I find them the most important ones. And then, of course, it's important to think of psychosocial factors that stress the parent, like housing, like employment, etc. And also to be critical about any approach you use like that it shouldn't lead to stereotyping, but to, just inspire us what to ask, so that we can be on the same page as our patients. Dominique summarized the diversity-sensitive health worker as a person that shows empathy, self-reflection, and experience, and is able to integrate those 3. And the most important part is probably also to know that all of us have the prejudices, and to know when they get ahead of us. For example, for me, it's like at night shifts, 4 a.m. when I don't want to see a patient in the first place, and then you go and have a hard time with somebody. So it's very good to be reflective about those, and then they're already less likely to influence the care we deliver. So one study that we did here on a factor that is also highly influenced by confidence, also by access to care and many, many other parameters, but also by the confidence. If you feel like vaccination is something you should give to your child or not is the COVID-19 vaccination. And we do know that the COVID-19 pandemic had important effects on the health, negative effects on the health of children, and particularly on children put in vulnerable positions. The vaccination, of course, is a key tool to control the pandemic and therefore reduce those negative effects. But and we do know that there is very heterogeneous vaccine uptake depending on the country you study. But relatively little is known how this plays out in people who cross international borders and therefore become migrants. There's one beautiful Lancet Infectious Disease study out there that tells us that refugees are at high risk of under-vaccination in Europe, but we didn't know how this would play out in Canada. So we did a study and differentiated between immigrants, that's mainly the economic immigrants, resettled refugees, and the protected refugees. We designed it as a population-based cohort study with an index date starting on January 1st, 2021, a look-back window of 1 year, and then the observation windows adapted to the 2 distinct vaccination campaigns, the one for adolescents starting on May 23rd, 2021, and the one for the children who started half a year later. And we followed them all the way up till April 24th, 2022. We first reported the crude rates of vaccination because they themselves already can drive a whole public health campaign. And then we developed this first logistic regression model to really understand how the immigration category influences vaccine uptake. So whether you're an economic migrant or a protected person or a resettled refugee. And we also looked at the non-immigrant characteristics. And then in the second logistic regression model, we really zoomed in and only included the migrants, differentiated between first and second generation migrants, and had a close look at all the further immigration characteristics like region of origin, how that influences COVID-19 vaccine uptake. So we included about 2.2 million children that were nearly equally distributed between the 2 vaccination campaigns, and a third in each group were first or second generation immigrants. That matches our epidemiological data. And the children's cohort had an uptake of 53.1% and the adolescents 79.2%. What was really interesting was that compared to other Canadian children, immigrants were more likely to be vaccinated, particularly in the children's group, and resettled refugees were having lower odds for vaccination. And this lower odds for vaccination also persisted in the second generation. The same effects were visible in the adolescent vaccination campaign group, just less pronounced. So all the red squares are closer to the bar in the middle. My favorite outcome of that study was actually the significant variation in immigrants and refugees by region of origin. So the black dots are the first generation immigrants, the red squares, also the tiny red squares, are the second generation immigrants. And what you can see here in those 2 different vaccination campaigns is that in both groups, but particularly in the adolescent group, the Southeast Asians are really rocking it. Like they have odds ratios of like 2.4 and more, in the adolescent group, even 4.4 for vaccination compared to each group average. Whereas those from Central Africa and from Eastern Europe have very low odds for vaccination. And in those with low odds for vaccination, you see that the black dot and the red squares are close together. So the first and the second generation are close together. So even the low odds are kind of persistent across generations. So for this study, we concluded that the study helps us to better understand COVID-19 vaccination inequities in immigrants, and that it can help to build stronger vaccination campaigns, better control the pandemic, and reduce negative effects on healthcare facilities. And what's really important to me is that this shows that we need precision public health approaches that really understand specific barriers to vaccination in those subgroups identified, for example, the Eastern Europeans or the Central African population, and then target their immunization strategy to that specific group and not put everybody in the same pot. And you'll likely not had a successful vaccination campaign. And that's important for COVID-19, but of course also for all the other immunization campaigns. So let's now focus on the third challenge, the one that all of you mentioned straight ahead, and that's communication. In our emerge in Switzerland, also motivated by the case of Jonathan, where an interpreter probably would have helped us to get a better triage score for him, we wanted to figure out, okay, how many of the families with limited language proficiency actually get an interpreter? Very simple question. So we took all the patients that presented and screened them for their language proficiency. And we were really pragmatic. So there's a score out there from Goethe Institute, which is like the renowned German language school worldwide. And they define A1 and A, B as really limited language proficiency, and B1 would be the lowest intermediate language skill level. And we were really pragmatic and said, okay, we define B1 and above as fluent and only look at those who have A1 and A2. So that's really people who know a few words, or in case of A2, maybe 2 or 3 sentence words, but really, really limited language proficiency. And then we identified those families and looked who received an interpreter and who didn't. And then we did an intervention. So we implemented this language proficiency pathway, where triage all those parents who have another nationality. I asked, can you please tell me why you're here? And if the nurse feels, we cannot communicate well, she already flags them as needs an interpreter. If she feels that's fine, she asks the second question, does your child have pre-existing conditions? If again the answer is great, perfect, she moves on to the question, do you need an interpreter or want an interpreter? And if the family doesn't want, she flags them as no interpreter needed. And if any of those questions are marked as positive, then the family is flagged as a family that needs language interpretation. Then the medical team actively offers them the interpretation, and the clerk of the ED organizes the language the language line, so that the goal was to reduce the administrative workload for the doctors. Then we assessed, after implementing all this, again, how many of those families with limited language proficiency receive an interpreter. And we got the numbers that before the intervention, 11% of those families with significant limited language proficiency received an interpreter, and after the intervention, 14.8%, which is an increase, but we're still a way to go. I mean, if I put it the other way around, it means 85% of those families don't receive language interpretation, therefore inferior healthcare. In a second step, we wanted to get the perspective of the caregivers and did a mixed method study. We had 14 caregivers in our study that received professional language interpretation, 167 without professional language interpretation. What was not very surprising is that those who received professional language interpretation were extremely satisfied on a score from 1 very poor to 6 excellent. They on average gave us a 5.5, so they were really happy. And the other ones were 4.8, so still kind of okay. And I would like to ask you the following. The caregiver who said that citation, what satisfaction score do you think did he give us between 0 and 6? The caregiver said, I did not understand what exactly was done during the operation. So that was a caregiver in the group who received no professional language interpretation, whose kid received a fracture reduction, and who at no point had professional language interpretation used for him. So what do you think? What was his or her satisfaction with our care? Was it 1, so super poor, 3, intermediate, 4, really high, or 6, very high? Yeah, I would have guessed the same. She or he gave us a 6 out of 6. So let's keep this in mind for a second. this was our result that summarizes the satisfaction of healthcare workers, families with limited language proficiency with the care they received. And really important factors influencing their satisfaction were, first of all, their health concepts and their past experience. And that was shaped by their cultural background and individual values. So if you remember the whole migration journey and how different the healthcare was that they received, this, of course, influenced the expectations with which they came into the health visit. Again, despite this being a completely different hospital, completely different caregivers, they emphasized that the relationship to the staff was very, very key for them, for their satisfaction. From the other side, so the green side, so the health workers and institution side, people also had their health concepts shaped by their cultural context and the institutional and individual values. And the second parameter that was also very important was the patient management. So that was mainly waiting times and the CHES system. The last factor that influenced the caregiver's satisfaction was the health outcome. So our interviews took place a week after the actual health encounter took place. And if the kid was fine, they were more likely to be happy with whatever they received. So the most important thing for those who were highly satisfied was that the provider and the caregiver had a trustful relationship, that their health concepts and the health concept of the institution aligned, and that the patient management matched their expectations. And the glue between all those bricks was communication. So communication allowed us to, for example, explain a family unfamiliar with the triage system, why another person gets treated before. That was very important, or to kind of explain why we don't want to use antibiotics or not use an IV rehydration, prefer oral rehydration. That was all possible with communication. So that was kind of our tool to try to align health concepts, patient management expectations, and to build trust. And now let's get back to that caregiver who gave us a 6 out of 6, despite having not understood anything what was going on. So surprisingly, we found that all those caregivers, where no professional interpreter was used, were satisfied with communication in nearly 45%. And the major explication for that was very low expectations, and that is a phenomenon called internal discrimination. So you're basically so used that you have inferior communication if you go to the supermarket, if you go to school, if you talk to a teacher of your children, if you go to daycare, if you go to an office, that you kind of get used to it and you don't expect the emerge to be better. And that's why those families were still happy, although from an outsider perspective, you're like, this is impossible that a parent is so happy if the kid got surgery and nobody explained properly to that caregiver what was actually done. A second reason, although a little bit less important, was that they overestimated their own language skills, particularly if they were not A1 but A2. And then third, only 20% knew that there was a free of charge and immediately available interpreter available. So one parent said, I would have liked an interpreter, but I was afraid that the organization would take too long. Again, competing interests. That mother had 4 additional children at home. It already took 3 hours, so she wanted to rush home and not extend the stay longer than needed. I didn't say that I didn't understand certain things, and I simply said yes. If I had known that there were also phone interpreters, I would have very happily used one. So our conclusion of this is that caregivers with limited language proficiency are not in a position where they can advocate for themselves to get professional language interpretation. And therefore, this is really a major responsibility of the medical provider to ensure patient safety. There's no way that we can turf that to our patients. It's our job as much as it is to have a good hygiene before we do a lumbar puncture. Let's now move to the micro level, so the families level. You have already seen this. That's the migration cycle once more. It's just a little bit differently designed. And what I want to show you with this is that each family that comes brings a unique mix of social determinants of health. And those different, some of them do not only influence separately the health of the patient, but in the combination are much more powerful than just the sum of each separate social determinant. So for example, if you're unaccompanied and you are a female, your risk to be sexually abused increases tremendously, much more than if you're only a female accompanied or only an unaccompanied male. And this is called intersectionality. So that's a very important concept in migrant health when you think about your family and the different potential risk factors for receiving inferior healthcare, that you have to really take them all into account and not just each of them separately. The second important thing I would like to mention for pediatric migrant health ties back to the definition of the WHO right to health in 1948. And that is that we have to take the psychosocial development of the children into account, particularly when there's something really important happening in their life, like migration. And that is the psychosocial development developed by John and Erik Erikson. It divides our life in basically 8 different challenges. And if we solve one challenges, like the first one, developing trust versus mistrust, we enter in the next period of life and can solve that life challenge, again, hopefully successfully. And if you have now, again, our example with the girl who is an unaccompanied minor and gets sexually abused during her 5-year-long escape, you can see that she's right in the stage of developing intimacy versus isolation. So such an abuse harms her even more than any other woman would be harmed, because she's just in that vulnerable stage of trying to develop this intimacy successfully. So it's very, very important when you have certain health incidents to take the psychosocial development of that person into account. And the second thing I would offer you a pediatric migrant migration cycle is to take the travel unit into account. So was it an unaccompanied minor? Was it a child just flying with his family first class, paid by a big software company for 8 hours from New Delhi? Or is it a person who lived 8 years in different refugee camps with the family? So to wrap this whole run through up, what can you take home? What important migrant health frameworks, models on the global, institutional and individual level do you know now? Just shout anything out that you remember. Yay, thank you. Yeah, that probably all the families I talked to would put that first too. Yeah. Intersectionality, absolutely. Yeah. Yeah. I like that one too. Don't deceive, just ask.
Thanks so much, Julia, and for being, I think, as far as I know, one of the first speakers to use this interactive model, at least, since I've been paying attention. So we have just a few minutes left, so I just wanted to open up and see if anybody, maybe we can have time for 1 or 2 questions. I don't see any hands raised, but if there's anybody who would like to ask Julia anything. You can also just turn your mic on and well, it doesn't seem like there are any additional questions, and of course you've been interacting with people as you've gone along. Do you have any last questions, Julia, that you wanted to pose to the group?
No. I'm absolutely fine. The only thing I would love to mention is that I'm thanking you for your attention and running with me through this maybe a little bit dense talk, but I hope you liked it. And I would love to thank Jonathan and his family for participating and all the families for teaching us so much, and also them for sharing their story with us, and the picture and the case for teaching purposes.
Thanks so much, Julia, and thank you to everybody. Bye-bye.
Bye-bye.